If there's no hypermobility present, but they were historically hypermobile on the 5-point questionnaire, 2 or more out of 5, and musculoskeletal issues, then they're a historical hypermobility spectrum disorder. Okay, so this is more your older people, your fibros, and the people who've collected a lot of injuries from a young age. Excuse me. There's also a localised HSD, which is single joint, and peripheral HSD, which is more hands and feet. Don't see as many of those because they obviously don't seek me out as much. All right, so then there's a heading here. So my headings aren't working. So this is, do they pass the hEDS criteria? So the link for the criteria checklist is down at the bottom there. So they must have something from category 1, 2 and 3. Okay, I'm not really going to go into that. But the primary diagnosis of other individuals in the family is probably the most helpful one. Remember, when this was pulled apart by the International Consortium, it was pulled apart for research so that when they had people defined as hypermobile EDS, they could look for the genetic markers. Okay, that was the primary reason it was done. Before that, EDS and JHS were the same thing. Okay, it does not mean that if you do not have EDS, you are not as severe. The spectrum does not necessarily follow in that way. It just means you don't fit this specific criteria. The other thing you need to think about is even if, so I won't diagnose this at this point because I'm not allowed to do any blood tests or workup to exclude other conditions. So that's why a lot of people end up at the rheumatologist or geneticist, okay? If the geneticist will see them, okay? And same with the rheumatologist, of course. But if you're going to send someone for this, just make sure that it's necessary. And I think it's necessarily in that severe group of patients who have multiple specialists, because the specialists will listen to hypermobile EDS in a way they don't listen to generalised hypermobility when they're looking at the type of suturing they're using when they're doing surgery, in the way the anaesthesiologists treat them, in the way that they'll preload them with saline and understand that they're more likely to have blood pressure and heart rate issues in recovery. So it facilitates our funding for DSP and NDIS, okay? But it's also a genetic diagnosis that affects your insurance and the insurance of your children and all that sort of thing. So keep an eye out for red flags, circulatory and cardiac abnormalities such as an artery aneurysm dissection AAA. So we could be thinking vascular EDS, Loeys-Dietz, or Marfan's. Lens dislocation or corneal problems, again, is another Marfan's type of diagnosis. Spontaneous pneumothorax can still be seen in hypermobile EDS, but again, I think it's worth checking it out. Rectal or uterine prolapse, and a history of AAAs, brain bleeds under 50, early deaths in the family that have been unexplained, or connective tissue disorders. Remember, these things travel in families. So if someone's presented to you at 55 and said, I think I've got vascular EDS, they wouldn't really be still alive, okay? So the mortality rate is that most people don't make their 40s, and it would have to be a spontaneous mutation of a very rare condition for that to be the case, okay? Because there's a family line. If you're thinking about things like classical EDS, then you're looking at excessive skin extensibility, scarring, and I'll show them in the next slides. Recurrent low force fracture, osteogenesis imperfecta is in this group of connective tissue disorders as well. There is a new criteria on diagnosing of hypermobility in children, which Louise Toffs will be speaking to after lunch, so I'm not really going to go into that. Basically, it's looking to the age of biological maturity, and it's taken away the EDS label for those before biological maturity and broken them down into different types of generalised joint hypermobility, including the subtypes of systemic involvement, musculoskeletal involvement and skin involvement. And there's quite a detailed flowchart, which you can always look up if you're interested. Across the lifespan, okay, people always say to me, why is it that I've been hypermobile, like I've been like this my whole life, why am I suddenly getting problems now? So it often becomes more symptomatic at times of altered loads on the body. So in childhood, hypermobility is common amongst kids. We're looking around that 40 to 50% level, and more so the younger that they are. But there's different groupings in this age group. So there's either the low-tone clumsy kid versus the sportsman, okay? They tend to hit problems if they have an injury and then can no longer exercise frequently. They get labelled with growing pains and just basically dismissed by adults that kids can't be in chronic pain. Adolescence, high risk factor time for teenage girls. Not only are we looking at the POTS onset, those gut things, but also trying to deal with growth and the start of hormonal changes. And this is where the percentage drops down for the boys. So is the testosterone itself protective, or is the extra muscle protective? And I suppose we really need some studies in trans men to get that, to see those changes. Would be interesting. Next one's higher education and full-time work. And then in this group, those who've succeeded to get to this point tend to just work really, really, really hard and ignore what their body is telling them. And then career burnout can often occur. So I don't see as many in this group when they're at work and burning out. Usually don't see them until they absolutely burn out. The problem with this group, if they are on the verge of burnout, they won't listen because they're just so caught up in the emotionalness of being a good worker and being a good everything. So they're really hard to get through to. Pregnancy and motherhood's the next one. So hormonal and biomechanical changes in combination with the lack of time for self-care. Peri and menopause, so the hormonal changes and increased presentation of tendinopathy, but the joints are stiff, so it's no longer present. So that's when the fibromyalgia diagnosis is common. And then in the geriatric group, this is often discovered when the children and grandchildren are diagnosed. And they tend to have a lifetime of medical trauma, a lot of mental health problems that come along with that, and a lot of chronic disease. They can still be strengthened up, but pain's definitely hard to mediate in that group. So I'm not going to go into any of this because all the other lectures are speaking to it, but remember that hypermobility is just the tip of the iceberg. This is the bit we see as therapists, and then all this is going on. So we've got chronic widespread pain, dysautonomia and POTS. Very rarely do I see someone with symptomatic hypermobility without a touch of POTS, okay? Sometimes they test negative, but you have to get them when they're having their hormonal cycle or they've just spent 3 days on their feet at a conference, and then they'll test positive. Chronic fatigue, which is more disabling than even MS and cancer. Gastrointestinal tract, 62%. So they went to a EDS clinic and found out how many people had gastro problems. Then they went to the functional gut clinic and found out how many people passed the EDS criteria, and it was the same back the other way, around 60%. Gynecological issues, double the incidence of everything. Mast cell activation syndrome, craniocervical instability is quite common. I do have a slide on that. Anxiety, which you'll hear more about later today. Neurodiversity, 7 to 8 times more likely to have ADHD or autism or the combo. And it's these problems, these co-occurring issues, that often make our management difficult and put roadblocks on our way on the path to rehabilitation. All right, so if we just talk a little bit about the comorbidities. Now, I'm a strong advocate for the fact that if we know about this stuff, then it's our job to give generalised advice to these clients about what the baseline conservative measures, and in those cases that we don't feel confident, we can write an email, a letter to the GP saying what we think we'd like to discuss with them and just getting their input on that if you don't feel quite ready. So pain education, yes, but be careful. They're very sensitised, okay, from issues in the past. Pacing activity, advice, activity tracking is very important. I love acceptance and commitment therapy and mindfulness meditation, as well as psychological support. We do a lot of decatastrophisation around movement and exercise, mostly by showing people a different way to move and showing them that it feels better. Advice regarding the systemic manifestations, so the salt fluid compression recovery positions, the gut and pelvic floor support, the sleep hygiene and quality, immune and allergy support, so simply things like reminders of removal of irritants from the environment. Most people know that they've got a dust allergy and they can't have gluten, but they're not necessarily always on top of it. So sometimes just reminding them of that. And then hormonal cycle support. I'm just going to have a quick drink of water. So this slide should say craniocervical instability. So we got a paper published last year, okay, an international consensus of therapists on this one. So if you think about CCI, it's actually CCI and AAI together make up a cervical instability, okay? And we're looking at in a mild way, around 50% of people have some signs, whereas a more severe percent would be maybe 5% of those who are symptomatic with hypermobility. Now, those severe ones are the ones who are in bed, okay, or wheelchair bound for short periods of times. So symptoms, the big things to look out for: post-occipital pain with a headache, worse with prolonged upright or speed bumps in the car. You feel like your head's a bobblehead doll, or it feels heavy and people are holding it up. I had one girl, when her head fell back, she needed her mum to come and lift it back up for her, okay? Severe cases we discussed about, you can get neurosigns, even with the mild cases, but as you get further on, the neurosigns worsen. And the treatment is neck and shoulder muscle rehab, okay, and special interest physio. Soft collar and hard collar is very it's great to improve function. I don't know how to say that word. And they're looking at things now, they're doing some halo trials to see if that improves function, and then going to fusion if the halo is a positive trial. There's also a working group working on prolotherapy with CT-guided injections, okay? And they're looking at doing that prior to halo. So this slide probably should say, so how do we do that? I think, or something like that. So how do we strengthen without injuring? How do we develop trust with clients who have multiple negative experiences? How do we stick to the plan when progress is slower than expected? So knowledge, compassion, and patience, okay? So why do I feel so stiff? This slide should say. So stretchy, so this is where everyone thinks a hypermobile person should be, like a rag doll. This is what they actually feel like most of the time. So stretchy ligaments allow joints to move further than average. Muscles around the joints partially co-contract continually to compensate for the extra joint mobility. The muscles often then feel tense and full of knots, and it's this co-contraction that often adds to the pain and joint subluxation. So if we're going to manage these guys properly, we keep thinking about dealing with the upregulate the muscle strength, control and stability, but if that's all we're doing, we tend to lead them to stiffness, flare-up and failure to complete rehab. We also have to work on the down regulation of the joint and muscle stiffness and holding, but if we just do that, then too much leads to injury, worsening instability and failure to progress. So you do have to do both. So this one would probably be called reducing tension or something like that, decreased stiffness. So I think the first one is just getting them to learn to let things go, okay? Breath control is really important. Acceptance of surface and relaxation. So give them this idea that even when they're lying down, they're probably hovering off the bed a little bit and just letting things go, because they've got this idea that if they hold everything tense, then that will keep them more stable, which is actually the opposite of what actually happens. Trigger balls are great. Suction cups for self-releasing is a really nice, and Ramona talked to this yesterday as well, which was interesting, and it's good for parents doing it to kids who also have hypermobility, who don't have the thumb strength to massage their own kids. Dr. Graham, general purpose massager, absolutely amazing. Cairo over in Perth invented this, and it's much less injurious than a Theragun, okay? It's more fascial layer. Contract, relax, appropriate stretches. Okay, this is my kid. Yay, I'm really flexible, mum, look at my back. Okay, so if we can actually teach them to keep the proximal area still, then we're going to get a much better stretch. And I'm not saying they need to do lots of stretching, but sometimes it just feels nice to have a little stretch, and I don't think we should be demonising stretching, because then that's causing more fear of movement. And then, of course, mobilised massaging and needling, big role to play. If you loosen someone's up, chance, and then they can go do a Pilates class, do it, because that's the only way we're going to get them moving. Decrease the strain on the musculoskeletal system. So postural neutral, again, we see a lot of this hyperlordotic posture. And there's another slide on posture we'll go into a bit more. Kinesio tape. So this is a shoulder. Okay, so there's the acromion, there's the head of the humerus. This is with the tape on. There are lots of different tapes that you can sometimes find one that they're not allergic to. The dynamic tape's good. Sensitive rock tape's good. Spraying with skin prep can help. Okay. So then if we think about strengthening, it's a little bit of a balancing act. Okay. So if we think about the muscles, then they can reinforce the ligaments and the joints and provide around 70% of the dynamic stability of the joint. So just because something is weak from a structural or a ligament point of view doesn't mean we can't get some really good work on the muscular system and the stability in that sense. So this should say, deep stability, okay? So we're looking at things like real-time ultrasound if you've got one, isometric low load, maintaining the breathing. There is some research that shows spinal stabilisation exercises in JHS helps women. I think core we've gone around the block on. I still teach it at times, okay, but I probably refer to it a little bit differently and use it as a way to untrain an abdominal bracing pattern. And to show them that actually to get a transversus contraction is very possible if you just let everything go. And then when we're moving into standing and Pilates, I very rarely will ever cue anyone to pull on their pelvic floor or their transversus or anything, because if they're in the right posture, it will be automatically working, all right? And then if we tell them to suck it in, we're just going to lead to a co-contraction overload. Joint stability, okay, looks like these slides are a little bit out of order. In fact, I don't think this is my talk at all. But anyway, that's fine. So motor control, the most important part. So we're looking at use your neuro training, so your Carr and Shepherd approach. So thinking, watch the move, what's happening that's unusual, and then change the muscle strength and then put it back into function. So giving the body some alternative movement strategies. So yes, there are different ways to move, but there's some really weird things that these clients do that are very inefficient way to move, okay? Beware of the other joints in the kinetic chain, use a lot of visual and tactile feedback, and be particular and review and monitor closely. So if we have a bit of a think about posture, so these are some common postural positions that people stand in. And I think I have spent a lot of time looking at how they're standing. Now, as soon as you say, I'm going to look at you, they stop standing like this and start standing like this. So I think that bit in particular at the end of the session when they're paying and seeing how they stand then is a more typical of how they actually stand. And so I usually say, okay, show me your posture. And then I say, is that where you live? And then they go, no, I live here. And so you get a bit of an idea what not only the baseline posture is, but what they think is the best place to be. So they may stand here when they're at rest, and then they might go or something as a correction, and they've been taught that potentially by some other therapist in their past, or they've interpreted what the therapist has told them to the wrong place, okay? So here's just some examples of a client with how she came in. So she was presenting with anterior hip pain and anterior instability. And so she'd done dancing and everyone just told her, your posture's bad, your posture's bad. So she used to stand with this external rotation and the anterior pelvic translation, so that pelvis moved forward. And you can just see how unstable that would be when her feet are so wide and she's so far forward, how much lateral thigh gripping and how much thoracic spine erector gripping is going to be needed to hold her there. So it's very easy just to get her in front of the mirror and say, bring your feet in a bit. I didn't want her to be straight because she wouldn't be able to tolerate it. And just bring the weight of your hips over your heels without moving your shoulders. So here's a bit more about posture. So there's a lot of stuff in the literature about posture, and does posture matter? I think it does in this population, and I think it's about the way we talk about it. So persistent postures may increase compressive loading on structures and contribute to the pain. And commonly adapted postures that hang into the end range of position of ligaments and joints alter the forces around the joints and the muscles in an unideal way. So persistent time spent in these postures will cause adaptive shortening of muscles and lengthening of others, and inefficient control during tasks. And this is what you see over and over again. Increased lumbar lordosis, anterior pelvic translation, so the weight of the body falling over the toes, knee hyperextension, low thoracic spine extension with sternal lift, and a very flattened thoracic spine. You can see all through here how flat they are. Sometimes they actually have a lordotic thoracic spine there, that flat. A poked chin and neck posture, and an increased upper thoracic kyphosis and a poked chin to balance it all out. So if you look at that, then you get this list of what muscles you would assume in that position would be the tighter or the gripping muscles, and what would be the weaker or the low tone muscles. And then that's the way you direct your treatment. Okay, because if I'm going to fix that, I can't just tell them to stand differently, because if they've got no range, if they're say iliacus and psoas is an example, they're usually tight and weak. So I'm not going to be able to get it to stretch out until I get it stronger. So this is how I try to look at them from a whole body approach rather than getting stuck in to one joint. Okay, I think that's probably enough about posture right now. Let's look a little bit more about some pictures. So then we'll look at exactly the same thing for every other analysis of their body. So here's the initial single leg stance. We're looking not only where the body weight is falling, but what the pelvis is doing. And then you can see even just 6 weeks later, 12 months later, there's a much more efficient and balanced way to stand. Walking. So she was mostly crutches user. Didn't use the crutch very much, but didn't really have any balance without it. And then I think the next one will just start. Now this isn't without her thinking quite a lot. We have gone on to get an ADHD and an autism diagnosis, and we're working on now getting some stimulants to help their short-term memory problems. And then we got onto the NDIS via that pathway. But they're up to now, they're working from home in a sewing business, up to 7 hours, 6 hours, 3 times a week. And their ultimate goal is to move out of home. Okay. Proprioception is very important. I think you guys know that. Even just getting someone to close their eyes and see if they can find their posture can be a good way to work it. Do a lot of work on foam, because the BOSU is a big jump, okay? So that thick foam can be a really nice place for people to get a little bit of proprioception, and a bit safer than a pillow. Then we move on to muscle strength, okay? So our third component, this is when we get them to add progressions. So your body weight, your external weights, your alternate posture, your balance challenge, okay? But if they're going to go to the gym, that's great, but they need to maintain their form and stability throughout, and they need to be patient in the rate of progression, because you can only go as fast as the weakest area. That might start out with the hip, and then it might be the shoulder, and then it might be the foot, and you need to modify, and you need to be prepared for flare-ups. We use a lot of neuromuscular stimulation with the complexes. We hire them out to clients. They're very effective at finding muscles that no one can find. Cardiovascular work, I think this is going to be spoken to by others, but again, looking at your reclined position, your pool work. I love people cycling on a pool noodle. Keep the water temperature not a hydrotherapy pool temperature. Okay, it can be heated, but just a public cool heating, or else they'll be wiped out for a long time. Okay, so very close to the end. So I'll just show you this slide, which was, I suppose, to try to say, yes, that's all well and great that they're standing and balancing differently, but what does that actually equate to with their pain and their function? So this client presented with basically pain all over. Left-sided upper lumbar, abdominal pain, left-sided groin pain, right-sided upper buttock pain radiating into her lateral thigh. She'd been diagnosed with things like bursitis. She had an L5-S1 nerve compression. So she'd had all these scans, but no one really knew where to start. So she was a 3 out of 5 on the 5-point hypermobility and a 5 out of 9, and multiple areas of musculoskeletal overload. And she worked in the health profession, so had a fairly good knowledge of things. So we diagnosed her with GHSD and inefficient control mechanisms when transferring weight around the pelvis. Okay, so these are her initial pictures, and then these are the 4-month follow-up pictures down here. Okay, so you can see the difference, and this is just spontaneous. Okay, spontaneous stance change. Okay, so you can see our angles. So once they can do single leg stance and they're good at it, then we have to look at single leg squat, because if they ever want to walk upstairs or a hill, they're going to need that pelvic control. So the angle here of how much valgus and internal rotation of your knee, as well as your Trendelenburg, are the signs to look for with that. So this one's looking pretty plumb. This one's still got a bit of work to go. So her treatment, she was co-treated with a women's health physio because we had a lot of pelvic floor overactivity, which made it very difficult for us to activate anything when everything was already on. And then we used our approach, including manual therapy and rehab, with a stability and motor control focus. She couldn't activate her hip flexor in any way. In fact, it looked like she was having a tremor or some type of seizure when you tried to get some of these muscles to work. So with her global rating of change, okay, so she slowly got better over time. 3 months, slightly better, 4 months, moderately, 9 months, very much better. So they do need to understand that there's going to be a longer term approach to this. Her pain reporting from initial to 9-month follow-up wasn't really that different. 50% pain frequency to 30%, worst pain from 5 to 4, usual 4 to 2. Okay, that's okay, because we had also asked her what were her 4 most problematic activities. So we had sitting, especially driving, lying on her side, urination, and intimate relations. Then at 9 months, prolonged periods of sitting, deadlifting a barbell from the floor, loaded hip flexion with a weight past 80 degrees, and bike riding to 30 kilometres. So if you just look at this, you're going to feel very sad when you go home from work and feel like you're doing nothing. All right? So very rarely do I actually specifically say, what's your pain frequency? I more say, okay, give me the updates, how are you able to implement what we did, what doctors have you seen, and we sort of case manage it a little bit more. And then this is her pain self-efficacy. So this is a scale of 0 to 6, with 6 being not confident at all and 0 completely confident. So she's gone from her 4 to 6s to 0 to 1s as her being able to cope with her pain in most situations. Okay, so I suppose that's just my little case study of I think that this method works, because once you get them transferring their weight, all of a sudden they can do a lot more and be a lot happier. So it's the Goldilocks principle, okay? They're rust in the middle, okay? And they're black and white thinkers. So this is my last slide. So don't move too fast or too slow. Don't be too straight or too slouched. Don't move too little or too much. Don't eat too much or too little. Muscles should be not too weak and not too tight. Understanding and not catastrophizing. Assessment, not medicalisation. Joint protection, not kinesiophobia. Not black or white. Try to find the grey. Okay? All right, so you might want to take a photo of that one. So this QR code will take you to my notjustbendit.com links where all this information will be there. If you guys aren't yet in the Facebook group Hypermobility for Australian Allied Health, please join, because I think we've got about 350 people on there. It's not a very active group, but it's really good for, does anyone know anyone in Darwin who's a doctor, blah, blah, blah. And also, if we ever do, we've got a craniocervical instability course coming up, hopefully towards the end of the year. And hopefully I'll start doing some actual hypermobility training courses the year after. You can also put yourself on the Ehlers-Danlos Syndrome Health Professionals Directory if you would like to receive referrals, because patients look at that. And also you can recommend the clients who can't afford regular therapy the Zebra Club, which is an app that Jeannie de Bon runs out of England. And it's made for people with hypermobility. And I've done her course. She knows what she's doing. It starts from a really low level, and then there's a code there so they can get 20% off their subscription. Okay.